A very good evening to all of you guys. A very warm welcome to all of you. So, yes, I'm able to see all your names over there, guys. After a long time, I have come here on YouTube to interact with you all. And this is Dr. Azam here, Faculty of Anatomy at DocTutorials. Yes, after a very long time, Abhishek, Open Sin, yes. So, very nice to see you, all of you guys. So already a lot of uncertainty going on with the exams, the exams getting postponed and all those things. Just to keep the spirit high, I've just come here so that we'll try to discuss certain, all the previous year questions that has been asked in the exams and some of the most important concepts. And nowadays, like a lot of questions are coming based on clinical aspect. I'm going to discuss certain clinical conditions over here. And apart from that, I'm also going to discuss certain image-based questions and all. Fine. So in this way, I'm also looking at your comments over here, guys. So I'll keep on interacting with you at the same time. And not only like this session, I'll like from here onwards, frequently I'll keep on coming on live to interact with you people, especially on YouTube at this platform here. So you can just wait for my updates. Whenever I come online or live, I'll just surely update you guys. Fine. So without any further delay, let's now get started with our first thing. Now what I will do here is that I'll discuss all the concepts in detail and we'll try to take up the concept with the help of a question actually. Okay, so we'll see like question by question, and along with that we'll try to discuss the entire concept related with that one. And not only answering that one particular question, we'll try to discuss everything in and around that thing, guys, that question, guys. And later on, after the end of the session and all, you can also let me know your suggestions, like which topics do you need. I'll like surely try to keep this, YouTube sessions every now and then, so that it will boost your confidence and even the topics will be actually revised. And one last thing, this will be surely useful for all the students who are going to write down, like whether you are writing the NEET PG exam or whether you're preparing for FMGE or whether you're preparing for AIIMS or whatever. It will be useful. Why? Because these are the very high yield topics in anatomy, like must know, you should know before going to the exam. Okay, so let us do one thing. Let's begin with the very first topic here, or the first concept that we are going to discuss. Now the question that you're able to see on the screen there, the nerve involved in Meralgia Paresthetica is it ilioinguinal nerve, or the medial cutaneous nerve of the thigh, cutaneous nerve of obturator nerve, or it is the lateral cutaneous nerve of the thigh, guys. Now the question is related to Meralgia Paresthetica. As I told you, I'm not only going to simply discuss the anatomy part, I'm also going to discuss many clinical aspects. Based on the latest trend, many clinical questions are being asked in the exam. So let's see the clinical aspect of this one here, guys. And just to keep this question aside, let us discuss the entire concept here, guys. Try to imagine this one here to be your anterior superior iliac spine. And this one here will be the pubic tubercle and the symphysis here. The pubic tubercle and the symphysis over here, guys. Pubic symphysis in the middle. Now between the ASIS, that is anterior superior iliac spine, and the pubic tubercle, between them you'll be actually having a ligament. And we all know that ligament between the pubic tubercle and the anterior superior iliac spine will be the inguinal ligament, guys. So imagine that one to be your inguinal ligament. Now, if that is your inguinal ligament there, somewhere here you'll be actually having a sheath, and I hope you have learned that in detail along with me many times. That will be the femoral sheath, guys. Fine, the funnel shape femoral sheath, and in turn it will be divided into like 3 compartments and all those things. But that is not our topic right now. Our topic is mainly about the cutaneous supply, to your thigh over here. My main concern and my first concept that I am discussing along with you here. Now you imagine this one to be your thigh over here. Perfect. Now my dear friends, I hope you have learned about the femoral sheath in detail. In that femoral sheath topic, one of the most important thing in femoral sheath is the femoral nerve. And remember, where is the nerve present? The nerve is not at all passing inside the femoral sheath. Femoral nerve is not passing inside the femoral sheath. In fact, it is actually passing outside. So the femoral nerve will be passing outside the femoral sheath here, sir. So imagine this one here to be your femoral nerve. So as I promised you people that I'm going to the entire concept will be actually revised in your mind. I have selected the topics in such a way that the entire concept has to be revised in your mind. So from here we have learned the first point today, that femoral nerve is not actually a content of your femoral sheath. It is actually present outside the femoral sheath. Perfectly done. Now after coming into the thigh here, the femoral nerve will be dividing into two divisions. One will be the anterior division of the femoral nerve, and then there will be one posterior division of the femoral nerve. It will be dividing into two divisions, the anterior division and the posterior division. And this also is a very important question already asked in your exams. Now what has been asked in your exams there, it is divided, the femoral nerve is divided to anterior division and the posterior division with the help of which artery? Like what is the criteria, what is the structure dividing into two division? Okay, so I'm even seeing your comments over here, guys. Okay, so try to answer whenever whenever I'm asking you certain questions, so try to answer there, guys. Yes, I'm even seeing your comments over here. So femoral nerve is divided to two division, anterior division and the posterior division with the help of one artery. Now what is that artery which is going to divide, sir? So there will be one artery present over here, and that artery, based on that artery, like one of the division is going in front of the artery and one of the division is going behind the artery. And yes, that is nothing but the lateral circumflex femoral artery. Lateral circumflex femoral artery, guys. And even that has been asked in your exam. Okay, so based on that artery, one of the division going in the front and one behind, so anterior division and the posterior division. So you can very clearly appreciate in my diagram here, yes, there is anterior division here, and this one here will be the posterior division. Yes, Dr. Chaudhary, Satvik Chaudhary, absolutely correct there. Lateral circumflex femoral artery. Fine, perfect. Now out of these two divisions, I'm not going to deal with the motor supply over here. I'm not going to tell you about the muscles and all. So my main intention is about the cutaneous supply, where most of the students will be actually having confusion. Motor supply everyone knows. Femoral nerve is the one which will be supplying to all the muscles in the anterior compartment of the thigh. Everyone knows that. Muscles, everyone knows. Now cutaneous supply. Now this anterior division will be in turn giving like two cutaneous branches. Now what will be the two cutaneous branches given by the anterior division? Remember, one will be the medial cutaneous nerve of thigh, and another one will be the intermediate cutaneous nerve of the thigh. So one will be the medial cutaneous nerve of thigh, another one is intermediate cutaneous nerve of the thigh. Now automatically the question comes in our mind. Guys. Then what about the lateral one, sir? I'm done with the medial, I'm done with the intermediate, and then what about the lateral cutaneous nerve of the thigh? Now remember, first point here, my dear friends, lateral cutaneous nerve of the thigh is not a branch of the femoral nerve. First point to keep in mind. Yes, it is not a branch of the femoral nerve. Okay, good evening Vitali. It is not a branch of the femoral nerve, sir. Why? Because the lateral cutaneous nerve of the thigh is a direct branch coming from your lumbar plexus. It's a direct branch coming from your lumbar plexus, guys. So for example, just for the sake of representation here, you'll be actually having your lumbar vertebrae there, like L1, L2, L3, L4, L5 and all. Now from the lumbar plexus, directly the branch, that is lateral cutaneous nerve of the thigh, is coming. So in first you have to remember, it is coming from where? It will be coming from your L2 and L3. It's originating from L2 and L3. So from L2 and L3, yes, you'll be getting the lateral cutaneous nerve of the thigh, and it will be supplying to the lateral aspect of the thigh, sir. So let us just write down there the lateral cutaneous nerve of thigh. The name itself is telling you, guys, it is the one. Yes, it is the one which will actually supply to the lateral aspect of the thigh. Very good, Weber. Very good, Weber. Fine. That's your lateral cutaneous nerve of the thigh. Now, what is the problem here? What is the clinical application here? The problem here is that sometimes what is going to happen, that lateral cutaneous nerve of the thigh will be compressed beneath that inguinal ligament. Okay, you can clearly appreciate there. Sometimes here it is actually compressed beneath this inguinal ligament over here, inguinal ligament, and because of that compression over there, yes, that condition is actually known as Meralgia Paresthetica. There will be like pain and paresthesia on the lateral aspect of the thigh. So that pain and paresthesia on the lateral aspect of the thigh, that condition is actually referred to as Meralgia Paresthetica. Meralgia Paresthetica. Perfect. So I think it can't be much more crystal clear than this one, guys. Okay, the concept is like very crystal clear there. So our thigh there, it will be supplied by medial cutaneous nerve of the thigh, intermediate cutaneous nerve of the thigh, as well as the lateral cutaneous nerve of the thigh. And out of these three, remember, only the medial and intermediate, those two are the branches of femoral nerve. And yes, for your NEET exam, I want you all to even remember those two branches are the branches of which division? They are the branches of anterior division of the femoral nerve, sir. So femoral nerve, anterior division. Anterior division of the femoral nerve will give rise to the medial and intermediate cutaneous, whereas the lateral cutaneous nerve of the thigh is not a branch of femoral. Remember, it's a branch coming from your L2 and L3, directly from the lumbar plexus, that is L2 and L3, guys. Perfectly clear. Understanding here? Yes, good evening Khan, good evening Ankita, a very good evening. Yes, Virat, already the important topic list has been provided in the DocTutorials app. I have actually made a complete important topics list in that one. You can always refer to that one. And yes, Virat, these are all the topics important for NEET as well as FMG and all. Thank you Divyanshu. Yes, I hope the concept is very clear. And one more thing, Divyanshu, I hope, not only Divyanshu, I hope all of you are observing here. As I promised all of you, it's not like only one question we are actually solving here. Okay. First point that we have learned here, femoral nerve is present outside the femoral sheath, number one. Number two, second point that we have learned in my diagram here, which artery is dividing the femoral nerve into anterior and posterior division? Lateral circumflex femoral artery. Point number three, femoral nerve will give only the medial and intermediate cutaneous nerve of the thigh, not the lateral. Okay, then point number four, lateral cutaneous nerve of the thigh is a direct branch from lumbar plexus, that too originating from L2, L3. And finally, the point number 5 that we have learned here, if it is compressed beneath the inguinal ligament, that is one leading to Meralgia Paresthetica. So even the clinical aspect completed here. Understanding here, guys? Yes, Dr. Javed. After a long time, even I am also in a very happy mode to interact with you people after a long time. And from here onwards, it will continue. I'll surely keep on coming every now and then to interact with you. Okay. So I hope this diagram is very clear, guys. So that's the concept here. So what is a nerve? Basically, what is the nerve that is involved in the Meralgia Paresthetica? It is nothing but the lateral cutaneous nerve of the thigh. So I was actually observing in the comment section there. Most of you have answered that correct one, guys. I'm really happy with this one. Is it okay? So this is the way how we are going to discuss the entire concept here. Perfect. So चलिए आगे बढ़ते हैं. Let's move ahead right now, guys. Let's move to the second concept. And remaining things about the femoral nerve, remaining things regarding the femoral nerve and all in detail, I have already recorded the app, guys. In DocTutorial, you can watch my entire lectures over there. So we can see now pertaining to this concept, everything is done here. Now let's move on to the next question here, sir. Thank you, crystal clear. Thank you, Khan. Thank you, Sindhu, Dr. Sindhu. Thank you for that. Yes, keep on listening. Now let us move towards next concept. So in this class, in today's class, I have kept the concept in such a way that, we'll even touch a little bit of embryology, then lower limb, upper limb, then, neuro, head and neck, like so many topics. Let us move towards the embryology part right now. The following cardiac anomaly is due to what? We'll see all the options later on, guys. First of all, look at this diagram here. In this diagram, yes, my dear friends, in this diagram, thank you, Arviv. Now, in this diagram, first of all, try to understand what is the anomaly. The anomaly here is that I'm able to see that there is a right superior vena cava here, and then there will be a left superior vena cava here. Oh my God. Like we're having two superior vena cava. We're having like two superior vena cava here, right and left one. Perfect. Okay. Now, I mean to say, what is the anomaly here? What is the cardiac anomaly here, guys? The cardiac anomaly is double superior vena cava. Now, the double superior vena cava will be due to what? Now, I don't want my student to just mug up the option over there. Okay. So let us see the little bit concept behind that one. And I'm going to make it like damn easy for you guys. Just be with me for another 5 minutes. And I'm going to make this entire concept damn easy. Basically, I'm going to teach you about the development of superior vena cava. And I promise you one thing. I will just teach you the normal development of superior vena cava. I promise you, and I'll challenge everyone, guys. at the end of this one, I mean to say another 5 minutes, you are actually going to answer me. Okay, you are going to tell me why that anomaly, why that abnormality will occur, guys. Is it okay? Fine. So let us first of all see like the normal thing. I'll teach you the normal thing and you tell me like what will be the anomaly in that one. Now everyone observe here, guys, during development of the venous system, when you study about the development, okay, the entire embryology part. So during development of the venous system, yes, there'll be 3 sets of veins, sir. Okay, there'll be 3 sets of veins. Yes, of course, Dr. Hashim Khan, it is even for FMG nowadays. Nowadays, FMG, NEET PG, not much difference. They're asking clinical questions. They are slowly moving towards the next pattern of exam. And within like, I should say like within a span of 1 year or so, everything is going to come onto a common platform. So it's common for everyone nowadays. You should know all this concept. And even in fact, Dr. Hashim Khan, development of superior vena cava has been asked in the FMG exam also. You can go back and check the previous year questions. Is it okay? Okay, chalo. Now, during development of the venous system, remember we'll be having 3 sets of veins, sir. How many sets of vein? 3 sets of vein. Number 1, every student knows about the umbilical vein. The umbilical vein, which is going to collect the blood or drain the blood from the mother. So from the mother towards the fetus, guys. So umbilical vein is the number 1. The second set of vein that we'll be having will be the vitelline vein. And in my diagram, you can see very clearly there, vitelline vein is the one which is going to collect the blood from yolk sac here. Okay. So umbilical veins are the one which are going to bring the blood from the mother, whereas vitelline vein is the one which is going to collect the blood from the yolk sac, guys. Perfectly done. There are 2 sets of veins completed. Now welcome to the third set of vein here. That will be your cardinal vein. And in the diagram here, you can clearly appreciate one is coming from the cranial end of the embryo. This one will be the anterior cardinal vein. And the other one coming from behind here, this one will be the posterior cardinal vein. There'll be an anterior cardinal vein and then there'll be a posterior cardinal vein, and both of them will actually combine together to form your common cardinal vein. That is common cardinal vein. Okay, so there will be anterior cardinal, there will be posterior cardinal, combines to form the common cardinal. So you can clearly appreciate there, I repeat again once more here, during development there will be 3 sets of veins. Number 1, umbilical vein bring the blood from the mother. Number 2, the vitelline vein bring the blood from the yolk sac. And finally the common cardinal vein, and that is actually the one which is collecting the blood from the entire embryo itself, entire body wall of the embryo, we can say. Now, I'm not going to go in detail of umbilical vein and vitelline vein and all. Now, let's think about the cardinal vein right now, sir. Cardinal vein. Cardinal vein is going to collect the blood from entire body wall of the embryo. Now, what you do is try to do one thing. Whatever diagram that you're able to see on the screen here, this is actually the diagram of embryo. And that diagram, let's try to compare with our body right now. I mean to say, compare the embryology with the gross anatomy. Understanding? So, what is going to collect the blood from the entire body wall of the embryo? Cardinal vein. And what is the vein which is going to collect the blood from our entire body? Vena cava, superior vena cava and inferior vena cava. Understanding? So therefore, I am getting a correlation here. Okay, that means cardinal vein is the one which is going to drain the blood from the body wall of the embryo. Definitely that has to become what? Our vena cava. So first make the concept, guys. Don't try to directly jump to the topic and mug up something there. Okay. Yes. Yes. So cardinal vein is the one which is going to become what? Superior vena cava and the inferior vena cava. I'm just telling you broadly here, roughly here. There's a lot of detail in that one. Is it okay? So that's a really nice Murugesan. I'm really happy. Very nice, Dr. Upen. I think I'm not able to tell your entire name. Upen Singh. Lockdown is here. Yes. Yes. Very good, Aishwarya. Very good, Tejasvi. Welcome here, guys. Out of these two, definitely, anterior cardinal vein is the one which has to become what? Superior vena cava. It has to become superior vena cava. But our topic is not the normal. Our topic is actually abnormality here. Now look here. So please narrow down right now. Forget about umbilical, forget about vitelline, and forget about the posterior cardinal. Narrow down your focus onto the anterior cardinal vein. And now, my dear doctors, just look at this diagram there. You might be thinking there is only one anterior cardinal vein. No. There'll be 2 of them. There'll be 2 anterior cardinal veins on both the sides. There'll be right one and left one. Sir, in this diagram, we are not able to see the right one. Where is that one? On the other side. This diagram of the embryo is actually a side pose. We are seeing the embryo from a side. So when you are seeing from a side, you are able to see only the anterior cardinal vein. Now today, let us do one thing. Let's turn the embryo in the front. Let me just turn the embryo in the front. See, yes, there will be a right and then there will be a left. There will be a right and there will be a left anterior cardinal vein. Is it okay? Yes, Prashant. Cardinal veins are the one which are going to collect the blood from the entire body wall of embryo. And out of that anterior cardinal vein, yes, they'll be actually paired, the right and the left one. And now what we'll do from this entire diagram, let us do one thing. Let me just make a simple diagram here, sir. Let me just make a simple diagram here. Okay. So how I'm going to actually make the diagram, it's like embryo turned in the front here right now, sir. We are looking at the embryo right from the front. When you look at the embryo right from the front there, then what is going to happen here? Yes, there will be one anterior cardinal vein here on the right side and there will be another anterior cardinal vein on the left side. So this will be the right anterior cardinal vein and this will be the left anterior cardinal vein. Perfect. Now there will be even a posterior cardinal vein here, guys, but I don't want you to get confused about that right now. Okay, why? Because we are going to learn about the posterior cardinal vein when we learn about development of inferior vena cava. Okay, and these two will combine together to form your common cardinal vein. That is your common cardinal vein, of course on the right side here, of course on the left side. Now this is what is extremely important when you're learning about the cardiovascular system embryology. Okay, cardiovascular system embryology, when you study, most of the students I have seen, they'll be directly jumping to the topic. We want to learn the development of superior vena cava, inferior vena cava. No. The most important thing is orientation. I have seen like thousands and thousands of students in my life. I'm telling you, throughout India, most of the students don't know the orientation. They don't know how exactly is this diagram oriented. Understanding? So welcome. Let us do it again, sir. So you also become an embryo. I'll also become an embryo as usual. Hamesha ki tarah. So embryo is first of all showing the side pose. You're able to see only the anterior cardinal vein on one side. Okay, anterior cardinal vein on one side. Now I'm going to turn. You'll be able to see on the other side. So let's see the embryo from the front now. Okay. So therefore, you'll be able to see the right and the left anterior cardinal vein. Now, I want all of you to just think about this one, guys. Think, okay? Don't try to wait for me to teach you and you just mug up that one, guys. You yourself think right now. Sir is telling that anterior cardinal vein on both the side, right and left side, that is the one which is going to form superior vena cava. But do we have like two superior vena cava? Do we have like two superior vena cava? Double superior vena cava? No. We just have only one. That too, we have observed that during gross anatomy we have seen superior vena cava is not even like exactly in the middle of the body. Not even like exactly in the middle of the body. It is more towards the right side here. That means what is going to happen here? What about the blood which is being drained from the left side? What should happen with that? That blood which is drained from the left side will be actually combining here, guys. That will also be draining here. How? And that is also brought here with the help of a vein, and this vein is actually referred to as your oblique vein. That's oblique vein. Okay. So from the right side as well as the left side, both of them will combine together to form your superior vena cava. So this is how finally what is going to happen here. Superior vena cava will be actually formed. Then what will happen to the remaining part on the left side, sir? On the left anterior cardinal vein, this part here will be actually gone, will degenerate, guys. Okay. Yes, very good, very good. I'm able to see all the answers there. Really happy with that one, guys. Dr. Tejasvi. Yes, it will actually regress. Now, that is how the right anterior cardinal vein and the left anterior cardinal vein, yes, they are going to be combined, anastomosis with the oblique vein there, and that is how superior vena cava will be formed there. Now it's your turn. Now the question is to you people right now, after teaching all this here, guys. Can anyone tell me right now, then why do we have like double superior vena cava? You can easily tell me right now. This is what is happening in the normal people like you and me. Like, why do you have the double superior vena cava there? What is the reason for that one? Before I teach you, I want the answer from you people right now, guys. Come on, I'm looking at your comments here. Why do you have the double superior vena cava then? I'm waiting for the right answer there. Come on. Thank you, Rahul sir. Thank you. Regress means it is gone. It is degenerated. Okay, Dr. Sahil, it is gone. Yes, yes, very good here. Suppose if this persists here. Yes, my dear friends, you can easily answer. Suppose if this persists, if this left anterior cardinal vein, if that persists, अगर वो रह जाएगा, if it persists, then what is going to happen? Yes, it will lead to the formation of double superior vena cava. So double, yes, very good. Look at that, lovely guys. Dr. Parvati, Dr. Soumya, Shweta, Tejasvi, Akshay, awesome, Rashid, Rishita, awesome guys. Yes. Dr. Rahul sir, I completely remember you. We have met in Mangalore, I hope. Bangalore, we were together. Yes sir. So Rahul sir there, our medicine faculty at DocTutorial. Thank you sir. It's my pleasure that you have joined here. Yes, of course guys. So persistence of the left anterior cardinal vein, that will lead to double superior vena cava. Are you getting my point here? So now you people tell me very frankly guys, okay, from your heart, you just tell me here, do you have to mug up these concepts? It's all about understanding once properly. You don't have to mug up this concept here. Unnecessarily double superior vena cava is formed by what? Persistence of left anterior cardinal. रट्टा मारने का जरूरत ही नहीं है. You don't have to mug up at all. Is it okay? So therefore, let us try to find out the answer here, guys. Let's try to find out the answer for this question. The following cardiac anomaly is due to what? In the image, you can clearly see double superior vena cava, and it's due to the persistence of left anterior cardinal vein. Concept made crystal clear. ठीक है ना? Concept made crystal clear, guys. ठीक है? राज ठाकुर इज लाइक सर ऑफलाइन क्लास में आप इतने शांत नहीं रहते हो. Yes, Raj Thakur, it's all getting recorded here, na? So you got to be like a little bit careful here. Chaliye, बढ़िया, that's really nice. Shall we go to the next concept now? I hope this concept is also cleared. So one, we have seen the clinical aspect of Meralgia Paresthetica, complete concept there. And one more, we have seen the concept in embryology, that to double superior vena cava. So previously in your exam, they used to ask just development of superior vena cava. It's developing from where? But nowadays, in more depth, clinically, why is there double superior vena cava? I hope you got the answer crystal clear. Thank you, Dr. Hussain. Let's go ahead right now, sir. Let's move to the next concept. Wow, look at this one now. The next question. In the next question, this is like nowadays the hot favorite thing. They have asked the question regarding Pterion in FMGE exam. They have asked the question regarding Pterion recently in the NEET PG exam. And slowly, what is happening, they're a little bit going in depth in this concept here. So what I am trying to do right now is that in this question, let us try to cover every point regarding Pterion. So if they ask again, you will be able to answer there right now, guys. Thank you, Rajat. Thank you, Dr. Rajat there. Yes. All of the following are correct statement about the given image, except what? First of all, in this given image, try to identify what is this highlighted structure here, sir. That is nothing but Pterion. That highlighted structure is Pterion. That is actually referred to as Pterion. Fine. So let me just write it here. This is Pterion. Now, it is actually a suture which is like H-shaped suture, guys. Pterion is actually the H-shaped suture. I don't want to take any risk for my students here. They're asking like many questions in almost every exam here. Yes, the marked one is Pterion. Very good, Prajwal. Now let us see every point related to that one here. Like how many bones are actually combining here? Totally 4. Now in this diagram, I hope you are able to appreciate here. This is the frontal bone here. The frontal bone. And then this one here will be the parietal. That is the parietal bone here. And then this one here will be the temporal bone. And remember, that is actually the squamous part of the temporal bone, sir. That is squamous part of the temporal bone. And finally, of course, there will be sphenoid bone. You are able to appreciate there the body of the sphenoid with the air sinus. Fine. There's a body of the sphenoid with the air sinus there. You are able to appreciate there. But which wing of the sphenoid bone is going to contribute or attach at the Pterion? That is greater wing. So I'll just write down here as greater wing of sphenoid, sir. Greater wing of sphenoid. Perfect. So what are the 4 bones which are actually joining at the Pterion? It's frontal, the parietal, the temporal, that is squamous part of temporal, and the sphenoid, that is greater wing of the sphenoid. Perfect. Now, apart from that, what are the important points that you have to note here? Come on, sir. All of the following are the correct statements about the given image formed by frontal, parietal, the squamous temporal, and the greater wing of sphenoid. Absolutely correct statement. That is a correct statement. Corresponds to lateral sulcus of your brain. See, when you see the diagram of your brain, something like this, the cerebral hemisphere is like this over here. And I hope you all know there will be a sulcus here on the lateral side, and that is nothing but lateral sulcus. Nothing but your sylvian fissure. And that lateral sulcus or sylvian fissure, that is the one which is corresponding to your pterion here. Okay, wherever you have the pterion, lying deep to that one, you'll be actually having the lateral sulcus. Yes, even that statement is also correct statement here, guys. Now, this pterion overlies the accessory meningeal artery. No, this is actually wrong. Remember, it is not the accessory meningeal artery here. It is middle meningeal artery. Middle meningeal artery. Middle meningeal artery. And not only that, you also have to remember the division, the anterior division of this one, guys. Middle meningeal artery, which division of that? Anterior division of the middle meningeal artery is the one where you have exactly the pterion. Pterion is overlying the anterior division of middle meningeal artery. Why I'm very specific about that? Why? Because in our exams, when you see the entire pattern, slowly they are trying to, increase the standard of this, the same concept only. Previously, they used to just ask pterion. What is the arrow mark structure? Pterion. Then they asked about which four bones are joining there. Nowadays, they're asking what are the underlying structures there? Underlying structures. So, I'm okay with, middle meningeal artery. I know all of my students know middle meningeal artery, but I want now my students to even remember the division also, the anterior division. Why? Because the middle meningeal artery will enter there and divide into two divisions over there. So there'll be a recurrent division also, but not recurrent. It will be anterior division present over here. So might be next time they'll go more in depth and they'll give you the anterior division. So be ready for that part. And blow in this region leads to extradural hematoma. Absolutely correct. If there is a hit in this region, if there is a blow in this region, then what is going to happen? That anterior division of the middle meningeal artery will be ruptured. A rupture of that will lead to epidural hemorrhage, extradural hemorrhage. Perfectly correct. So what I have done here in this, I have tried to cover like every point regarding pterion. Let them ask any question regarding the pterion right now. My students are absolutely ready to answer the question answer. Perfect. Let them ask anything right now. My students are ready to answer that one. Yes, Dr. Purvam. Yes, Dr. Prem Patel. I'm absolutely fine. Perfect that. Yes, thank you. Chaliye, आगे बढ़ेंगे. Shall we go a little bit in more depth right now, sir? Every point regarding the pterion has been covered here. So I want all of you to make a note of all these points and keep it ready. They can ask you any point from here. Next one, guys. Wow. Another hot favorite concept of the examiners nowadays. Another hot favorite concept of examiners nowadays. Dr. Amit is asking class till when? Class will be until unless you want, guys. Okay. So until unless you are ready to learn, I'm ready to teach here. I'm here for you people only. I have come here on this YouTube live just to interact with you people because it was so long. I was busy with actually recording for my lectures at DocTutorial. So I'm coming up with my entire app. So the entire anatomy will be available in the recorded format in DocTutorials app, guys. So I was a little bit occupied with that one, but now I'm a little bit free right now. So I'll just every now and then I'll come you before your exams. I'll come and interact with you people, guys. Is it okay? Is it okay? So we'll try to keep the session up to 6 o'clock like that. If you people are comfortable, fine. Let's go ahead, guys. Now the next concept. Yes. We'll try to keep the schedule our class up to 6 o'clock like that. Okay, na? 6. चलिए सर आगे बढ़ते हैं. Now, my dear friends, remember, now the next question that you are able to see here, the next concept that you are able to see on the screen over here, this is one of the most important concepts. Why? Because just last year, 2020, I'm telling you, that lockdown wala year, 2020, there was a question about attachment of muscles to the femur in almost every exam. There was a question in the NEET exam. There was a question in the Even in your FMG exam as well as in INS set also they have asked one question. So I'll tell you everything that is related with this region here. Why? Because nowadays it is the hot favorite one, guys. So nowadays it is a very, very hot favorite one, sir. The attachment of muscles to the upper end of the femur. Now, first thing what I have observed is most of the students are actually getting confused with most of the students are actually getting confused with what here? The moment they look at the diagram, how to identify or how to differentiate between the upper end of the femur, anterior view and the posterior view. How to differentiate between them, sir. Okay, anterior view and the posterior view. How to differentiate them. Now on the screen here, you're able to see like both the diagrams. Okay, one is anterior view, another one is a posterior view. Now how to differentiate is that out of these two diagrams, my dear friend, look here. You have to look at the lesser trochanter. Come on, guys. Learn the trick now. Okay, learn the trick now. Learn the trick along with me right now. You have to actually look at the lesser trochanter. Lesser trochanter. Lesser trochanter is more clearly visible in the posterior view. The second diagram that you are able to see here, this is the posterior view of the femur. And in this will be actually the greater trochanter over here. This is greater trochanter. And whereas this is the lesser trochanter over here, guys. This is the lesser trochanter. And my dear doctors, if you observe both the diagrams, that is the reason why I kept both the diagrams for comparison there. If you see both the diagrams, yes, in the second diagram where we have marked here, we are able to see the lesser trochanter much more clearly over there, very clearly visible there, and that will be the posterior view. Whereas in the anterior view, you'll not able to see the entire lesser trochanter over here. Why? Because it is present more posteriorly. That is one thing to identify the anterior view and the posterior view, sir. I hope you got the trick. That is a simple method how to identify the anterior view and the posterior view, guys. The anterior view and the posterior view. Is it okay? So in my classes, in my live sessions, no mugging business at all, guys. You all know very well. You have been along with me for a long time. And all the new students who are listening to me for the very first time, all my classes will be like very conceptual. Not like pertaining to only a particular one question and just mugging up that one. So it's not like only that question and just mugging that one. So let us discuss the entire concept related to that one. So what is the problem with many of the students is identifying which is anterior view and the posterior view. I hope now it is crystal clear. In the anterior view, you will not be able to appreciate the lesser trochanter very well demarcated, whereas in the posterior view, yes, we got it very clearly. Now in the anterior view, one more thing here, between the greater trochanter and the lesser trochanter, you are able to appreciate a line here, and that line is referred to as intertrochanteric line. In the anterior view, there will be intertrochanteric line, sir, very important one. Whereas in the posterior view, my dear friends, you can see between the greater trochanter and the lesser trochanter, you are able to appreciate one complete elevation here. Okay, I'm speaking about this one here, guys. I'm speaking about this part here. You are able to see a complete elevation there, and that is actually referred to as crest. That is intertrochanteric crest. There is intertrochanteric crest, guys. I hope you're getting me there. So on the posterior view of the femur, there will be intertrochanteric crest, whereas on the anterior view, there will be intertrochanteric line. I hope that is more than enough for you to identify the anterior view and the posterior view, guys. Now, once you are perfect here, my dear friends, remember, yes. Now let us see about the muscles which are getting inserted here. On the greater trochanter, you'll be actually able to appreciate the insertion of gluteus muscle. And here it will be actually gluteus medius. Gluteus medius muscle getting inserted here. So I'm trying to use the same color there, guys. The standard colors in our anatomy textbook. The red color for origin and whereas the blue color for insertion, guys. Okay? That is gluteus medius, and then where will be the gluteus minimus? That will be also on greater trochanter only, inserting on greater trochanter only, but that is more anteriorly, guys. So let me just show you on the other view here. Yes, here. So that is the gluteus minimus. So whatever, my dear friends, remember both gluteus medius and both gluteus minimus will be inserted onto the greater trochanter. Both gluteus medius and minimus will be inserted onto the greater trochanter, but medius will be on the posterior surface, guys. Perfect. So these two are inserted on which trochanter? These two are inserted onto the greater trochanter, and that was the question actually asked in the NEET PG exam. That was the question asked in the NEET PG exam. Now let's move towards the FMG exam right now. Recently, in the last year exam only, 2020, it was an image-based question, and they have marked the lesser trochanter and what is the muscle inserting onto this lesser trochanter over here. Remember, the muscle that is getting inserted onto this lesser trochanter here, that will be the iliopsoas. Iliopsoas muscle, the iliacus and the psoas major muscle, which is together referred to as iliopsoas. So this was the question asked in the FMG exam. FMG exam. Is it okay? Perfect. Now welcome to the ionized exam. Ionized exam, the question was actually about the maximus. Now where is the gluteus maximus? Even you might be looking for that one, sir. आपने medius and minimus बताया है, but where is maximus getting inserted? Welcome, my dear friends, here in this diagram. Are you all able to appreciate this tuberosity over here? And that tuberosity is referred to as gluteal tuberosity. This is gluteal tuberosity. Okay, and on this gluteal tuberosity inserts the gluteus maximus muscle. So gluteus maximus muscle is the one which will be inserting onto the gluteal tuberosity. Perfect. Not only on the gluteus tuberosity over there, guys, some of the fibers of gluteus maximus will also get inserted onto a tract which is known as iliotibial tract. Iliotibial tract. The gluteus maximus muscle will be inserting onto the gluteal tuberosity as well as iliotibial tract. And this was actually the question asked in the, that too image-based question asked in the INSET exam, and that too in 2020 only. So are you understanding the pattern here now? Okay, so in the previous exam, there used to be like more questions about attachment of upper end of the humerus and scapula, but nowadays they are more concerned about attachments onto the upper end of the femur. So I have like combined or concised everything in one diagram here, which was asked in your NEET PG as well as FMG as well as the INSET exam. So let us just summarize everything at one place. Gluteus medius and gluteus minimus will be inserted onto the greater trochanter, whereas the iliopsoas, iliacus and the psoas major will be inserted onto the lesser trochanter of the femur, whereas the gluteus maximus, some of the fibers are inserted onto the tuberosity, the gluteal tuberosity, and some other fibers of the gluteus maximus will also be inserted onto the iliotibial tract. Okay, so one question from the NEET PG and one question from the FMG, one question from INSET. Whatever it is, we are done with the insertion of all these muscles over here. Okay, fine here. Thank you, Dr. Purvang. That is really nice of you. Thank you. So now, my dear friends, that is about all these things. Let's go ahead now. Action of the muscle inserted onto the arrow marked region. So arrow marked region, you can clearly see there, that's nothing but the greater trochanter. And what is the muscle inserting onto the greater trochanter? The medius and minimus. I told you on the anterior and posterior surfaces there, whatever it is. On the greater trochanter, you'll be having medius and minimus. And medius and minimus, they're actually helping in abduction at the hip joint. Keep that in mind, sir. Abduction at the hip joint, sir. Okay. Thank you, Dr. Prem. Thank you, Jayashri. Welcome, Jayashri. Okay. So medius and minimus are the one which are actually helping in abduction at the hip joint. Keep that in mind, guys. I hope you also remember one more clinical importance of that. When the nerve supplying to that will be gone, if those muscles are gone, then what is going to happen, guys? The person will be actually, the gait will change into lurching gait, and Trendelenburg sign will be positive in that one. That's really important. Another important thing. So Trendelenburg sign will be positive in that one. And in my app, that is DocTutorial app here, I have recorded all the lectures of anatomy, and in that I have literally done the Trendelenburg sign positive, how it will be, how the person will be walking. So you can literally see or watch me walking in the same manner and showing you the entire gait, guys. Perfect. Yes. Let's go ahead. Okay, let's go to the next concept here. This entire concept is done. So I hope you're getting some advantage out of this session, guys. I'm sure you're getting some advantage out of this session. I hope your confidence is boosting up and even the concepts are getting revised. And as I told you in the very beginning of this class only, like I'm going to discuss the image based questions. I'm going to discuss the clinical questions over here. So I hope we are following the same thing here, guys. Fine. So let's go ahead now. All of the following nerve will cause the movement of the eyeball except which one here. So I'll do one thing. I'll just come back to this one afterwards. But before that, nowadays, they're giving this picture, this image. They're asking you to identify like all the nerves. So let us try to identify all the nerves here first of all. Now here also I'll tell you one thing here, guys. Previously what used to happen? Directly a question used to be given and in that the name of the foramen and the structure passing through the foramen. That's all. There used to be the name of the foramen and the structure passing through the foramen. Understanding? But nowadays you can understand how they're increasing the standard. Nowadays they're giving you not only the foramen, the image of the foramen, they are directly giving the structures passing. So previously, if you have seen my like other sessions and all, if you have attended my class, I used to just teach you about all the foramens there. But nowadays it's not only about the foramens, even the nerve passing through that you should be able to identify. Come on, let's update our knowledge right now, sir. Let's upgrade our standards now. Now, my dear friends, in this diagram, the moment you see here, yes, Dr. Priya, as I promised you all, every now and then, I'm going to come here. Okay, every now and then, I will be coming on this platform. Okay, YouTube live on DocTutorials platform. So just keep on waiting for my update in the Telegram group. I'll update all the details in the Telegram group, and whenever you get the link, join my classes. Is it okay? Chalo, sir, next one. Now in this diagram, first of all, you're able to see here, this is the cribriform plate. And what is this nerve which is going to pass through the cribriform plate? That is cranial nerve number 1. Of course, olfactory nerve there. So cranial nerve number 1, that is your olfactory nerve, is the one which is going to pass through the cribriform plate. That is cranial nerve number 1. No confusion about that. I'm sure 110% more than you. I have confidence in you people, guys. You can easily identify this one. Anyone can identify this one here. Now, not only that, even this one here, guys. This nerve over here, any student can identify here. This is your cranial nerve number 2. That is optic nerve. And optic nerve is actually going to pass through that canal. That is your optic canal over there. So these two, any student can identify very easily. The confusion will be actually in this area here. The confusion will be in this region actually. Okay, I will try to clarify the confusion here. Yes, listen my words very, very carefully. When we studied neuroanatomy, or I think you have learned a neuroanatomy a lot of time, I taught about the brainstem. And in the brainstem, the cranial nerve number 3 and 4 will be originating from midbrain. Thoda sa, little bit of background knowledge we require here. From midbrain, pons and medulla, from midbrain, the 3rd and the 4th cranial nerve will originate. And now, my dear friends, I am looking at the comment section there. Can you please answer me, like out of that 3rd and 4th nerve, which nerve has got the dorsal origin? Which is the only cranial nerve which has got the dorsal origin? Come on. Which nerve has got the dorsal origin? Come on, guys. Come on, my dear friends, answer me here. I'm looking at the comments there. Out of 3rd and 4th, which is originating from midbrain, which one has got the dorsal origin? Lovely, lovely. So Dr. Soumya, Dr. Mona, everyone there, perfect. Okay, lockdown is here. I don't know what kind of name is that one. Yes, perfect. The only cranial nerve which has got dorsal origin will be the 4th nerve. Now, after keeping that concept in your mind, please look at the screen now. Look at the screen now. Out of these 3 cranial nerves here, no confusion at all. This will be actually the 3rd cranial nerve. That's your oculomotor nerve. That is 3rd cranial nerve having ventral origin. But whereas the 4th nerve is the one which is going to take a turn from behind and then come in the front. 4th nerve is going to take a turn and come in the front. So because it's taking a turn and coming from the front, try to remember that point. And from that point, we can remember this is the 4th cranial nerve here, sir. That's your 4th cranial nerve there, guys. Awesome. Understanding? So don't get confused with that 3 nerves over there. The 3rd nerve is this one over here. which is having the ventral origin from the same midbrain only, but whereas the fourth nerve is the one which is going to take a turn and come from the front, and therefore this will be your fourth nerve over here, and this will be the third nerve over here. No confusion at all. Perfect. And in between that you are able to see one nerve, and that nerve is the one which is coming over that clivus part. Okay, that sloping part that you're able to see there, that is nothing but your clivus part. And from that clivus part, that sloping part, this one, let me just highlight there, is the clivus wala part. And from that, whatever this nerve is coming over here, guys, that nerve is your sixth nerve. That is the sixth nerve, and that sixth nerve will be coming over that clivus, then taking a turn, going inside the cavernous sinus, and from there into the superior orbital fissure. Perfect. That is the sixth nerve, guys. So that is the main important thing which I'm trying to put in your mind, and that is the place where I have seen 99% of the students are getting confused, and I don't want my students to be getting confused in this one here. So third nerve has got ventral origin from the same midbrain. Fourth nerve is coming from behind. That is why the fourth nerve little bit lateral there. In between them, that is your sixth nerve in the middle. That is climbing up through the clivus. Perfect. Are you all perfect with this one? And after that, no confusion at all. This is a ganglion here, and this ganglion is nothing but trigeminal ganglion. That is trigeminal ganglion, guys. Perfect. And if that is a trigeminal ganglion, trigeminal nerve, that is the thickest one, the fifth nerve, easy to identify, then easily you can see the three branches of that. Yeah, the trigeminal nerve will give rise to, this is the 5-1 ophthalmic nerve, and this one here will be the 5-2 maxillary nerve, and this one here will be the 5-3, that's your mandibular nerve, guys. So 5-1, 5-2 and 5-3, that's your three branches from the trigeminal, ophthalmic, maxillary and mandibular nerve, guys. Perfect. Okay. Welcome Pegasus. Welcome Adlin. Yes. Next one here. After that, what about this one here, guys? What about this nerve here? This one will be the 7th cranial nerve, facial, and this one here will be the 8th cranial nerve, that is your vestibulocochlear. 7th and 8th cranial nerve there, guys, facial and vestibulocochlear. And these two, the 7th and 8th, they are the one which are going to pass through the internal acoustic meatus, internal auditory meatus or acoustic meatus from there. And then you're able to see one more foramen here. This will be the jugular foramen here. And passing through the jugular foramen, you'll be able to appreciate the cranial nerve number 9 as well as the 10 and 11th one. And I think you are able to appreciate that 11th one accessory coming from the magnum, foramen magnum. It will be ascending up spinal accessory components. Again. So from the foramen magnum, you can see the 11th nerve coming up there. That is easily identifiable, guys. That is your accessory. And these will be passing through which foramen here? That's your jugular foramen. So let me just even write down the name of the foramen here so that you don't get confused. So these two are going to pass through the internal acoustic meatus. Internal acoustic meatus. And then there will be one more foramen here. That's your jugular foramen. Jugular foramen there. Perfect. Then what about this foramen, sir? There is a small foramen over here. That is your hypoglossal canal. And hypoglossal canal, definitely it has to be the 12th nerve, the hypoglossal nerve. I think that is not at all a confusion over there, guys. वहाँ पर ना किसी को confusion नहीं होता है. So the confusion is actually in the middle part. Most of the students I have seen, the confusion will be this part in the middle where there will be confusion, guys. So I think that has been clarified. No confusion about that, है ना? Is it okay? Dr. Soumya is telling there, इतने आराम से प्यार से कैसे पढ़ा लेते हो? इतने आराम से और इतने प्यार से इसीलिए पढ़ा लेते हैं क्योंकि because yes, that is a lot of love from my students that I get, and that's what keep me motivated always, and that's what keep me to come up again with some of the other new ideas so that it will be easier for my students. है ना? So guys, you are able to identify all the nerves. So what is our main intention in this question that we are discussing here about the head and neck topic? Head and neck topic about the cranial foramen. And previously we used to study the name of the foramen and structure passing, but nowadays they're giving image based question. Already this kind of image has been given in your exam. Hope you'll be easily able to identify all these nerves now. Okay. So therefore let's go back to the question now. Now coming back to our question here, guys, all of the following nerves will cause the movement of eyeball except what? Come on. What is this A here? A stands for optic nerve. That's your optic nerve there, guys. And then what is that B there? No confusion about that. That B will be actually your third nerve, oculomotor nerve. And what's that D there? D actually stands for your fourth nerve, the trochlear nerve. And in the middle of these two, you're able to see the sixth nerve, that is your abducens nerve. And guys, try to recall what is the nerve supply to your extraocular muscles. Extraocular muscles, which are controlling the movement of the eyeball, all that 4 recti, 2 oblique, yes, the nerve supply to them will be SO4, LR6 and rest all by 3. So SO4, LR6 and rest all by 3. The recti, the oblique and the levator palpebrae superioris, they'll be supplied by that. So they are the one which are controlling the eye movements. I think you have learned in the ophthalmology. But out of all that, you can clearly see the third nerve as well as the fourth nerve and sixth nerve are required for the movement of eyeball, but not the optic nerve. So except means the answer will be A. Optic nerve is not involved in the movement of the eyeball. I hope the concept is clear. Yes. So I'm sure, my dear friends, all my students who are along with me, listening to me live here on the YouTube, guys, I'm sure you all know the nerve supply to the extraocular muscles. Extraocular muscle nerve supply, you already know. I'm sure about that. SO4, LR6, rest all by 3. But the most important thing that we are learning here, to identify those nerves. So your focus should be always on that thing. So don't be happy that I know SO4, LR6 and rest all by 3. Everyone knows that. Even first year MBBS knows that. The important thing is identifying the nerves there. Identifying the nerves. And I think that has been made like crystal clear in this diagram here, guys. Okay, guys. So that is made like very, very clear in this diagram here about all the nerves and how to identify them. I give you all the logics there, guys. I give you all the tricks there. Is it okay? Perfect here? Thank you, Dr. Soumya. So guys, this is all here. I think we have discussed some important concepts regarding Meralgia Paresthetica, certain important concepts regarding head and neck, the cranial foramens and these ones. And I even told you about certain like embryology part, development of superior vena cava and all. So I hope all these concepts are crystal clear, my dear friends. So we'll do one thing. We'll actually stop this session over here. Okay. And after that, I'll again come up with many sessions. Don't worry about that. And I'll be waiting for your lovely suggestions, guys. Okay. So I need all your suggestions, like which topics do you need? We'll try to make them easier, guys. All this image based. And I'll even come up with the clinical questions and all. So don't worry. Every now and then I'll keep on keeping these sessions, guys. I'll come back again to meet you people, interact with you people. Okay. Until then, wait for the update in the Telegram group. I'll be updating whenever there'll be a session. And you can join here on DocTutorial. I'm having my entire anatomy app ready. So all the entire anatomy lectures will be recorded on that one, guys. You can just watch that on DocTutorials. Is it okay? So thank you all. Thank you all. I can see all your messages there, guys. So I cannot take up all your names there. But thank you all, guys. Dr. Parvati, Dr. Girish, Gautam. Yes, Dr. Rajat, Harvesh, Rathod. Yeah. Thank you, Dr. Soumya. Thank you all, guys. Okay. So thank you all for your wishes. Thank you all for that one, guys. So keep connected with me. I'll come back again on this YouTube live. Thank you. Take care. All the best for your preparation, guys.